So today we're going to be talking about the basics of oxygen therapy in low and middle income countries in the global south. I'm going to pass it along to the Stanford Global Anesthesia team now, to Dr. Anna Maria Crawford, who among her many hats is the founder and co-director of the Division of Global Health in Anesthesia at Stanford, and also is program lead, Global Humanitarian Outreach Committee for the American Society of Anesthesiologists. Anna, over to you.
Thank you. Good morning, Maramutse. Happy to be here and happy to have all of the participants. Looking forward to going through some basics of oxygen therapy today, and wanted to introduce the panel that we have that will help with discussions. We have Dr. Reema Patel, who is a CASIEF Global Health Fellow in Ethiopia and is currently a registrar in the intensive care medicine in the UK. James McAvoy, some of our listeners in Rwanda know him well. He's an anesthesiologist and also a critical care medicine specialist. He's at Stanford University. And then we have Dr. Andrew Lim, also in critical care medicine, but has a background in emergency medicine, and he's also at Stanford University. So would like to welcome those co-panelists today. Let's go ahead and get started. I'm going to go ahead and share my screen. So some of the information that you received in the email and the invitation led you to the Global Anesthesia and Critical Care Learning. Okay, so you guys can hear me. So in the pre-reading materials, you should have received a link to the Global Anesthesia and Critical Care Learning Resource Center. And within that Learning Resource Center, we have the Oxygen Series, Care of Pediatric and Adult Patients, which has the course objectives. This is a number of sessions in a series. In the first module, we have the background situation. We have a pre-course quiz, and then we have facility evaluation, which you can actually go through and try to evaluate what resources you have at your facility. We can go ahead and get started with the second module, which is how we're going to diagnose hypoxemia and how it's defined and how we detect low oxygen levels in our patients. So the first thing you can do is take a quiz, which I'll let you do after this session, or if we have time, we can do it at the end of the session. But I'm going to start here with the definitions and detection of hypoxemia.
Diagnosing and treating hypoxemia requires providers understand its definition and how to detect hypoxemia using pulse oximetry or arterial blood gas analysis. When we breathe, we pull air into our lungs. Room air contains 21% oxygen. When oxygen enters our lungs, it travels to the alveoli, where it diffuses from the alveoli into the pulmonary capillaries. Oxygen then either binds to hemoglobin within the red blood cells or diffuses into the plasma. This is called oxygenation. Insufficient oxygenation is called hypoxemia. The rate at which oxygen is delivered to the cells and tissues of the body is known as oxygen delivery. Inadequate delivery of oxygen to the cells, tissues, and organs of the body is known as hypoxia. Every cell of the body requires oxygen for cellular metabolism. Lack of oxygen leads to cell death, tissue death, and organ dysfunction. The rate at which oxygen is removed from the blood and used by the cells and tissues is known as oxygen consumption. Oxygen in the blood can be detected a number of ways. The majority of oxygen is bound to hemoglobin. This is known as oxyhemoglobin. The saturation of hemoglobin can be detected directly using arterial blood gas analysis, or can be detected indirectly using pulse oximetry. When oxyhemoglobin is measured by arterial blood gas analysis, it is termed SaO2. When oxyhemoglobin is measured using pulse oximetry, it is termed SpO2. The small portion of oxygen that dissolves into the plasma creates an arterial oxygen tension or partial pressure and is known as PaO2. Pulse oximeters measure arterial oxygen saturation, termed SpO2. Hemoglobin bound to oxygen is termed oxyhemoglobin. Hemoglobin not bound to oxygen is termed deoxyhemoglobin. Pulse oximeters shine light through tissue beds, usually a finger, a toe, or an earlobe. Then they measure the amount of light that is absorbed. Oxyhemoglobin absorbs light at a different wavelength than does deoxyhemoglobin. The ratio of light absorbed by oxyhemoglobin versus the light absorbed by deoxyhemoglobin is displayed as a percentage by the pulse oximeter. Non-pulsatile venous blood and tissues also absorb light. However, these components are discarded by the pulse oximeter. The pulse oximeter only uses the values obtained from pulsatile arterial blood flow. Normal oxygen saturation by pulse oximetry is greater than 94%. However, when administering oxygen therapies, an SpO2 greater than 90% is usually acceptable. Pulse oximetry is non-invasive and painless for patients. Arterial blood gas analysis, termed ABG, directly measures arterial blood gases, oxygen, and carbon dioxide. Values obtained from ABGs include the pH, the partial pressure of oxygen, termed PaO2, arterial oxygen saturation, or SaO2, the partial pressure of carbon dioxide, termed PaCO2, bicarbonate, and base excess. Blood gas analysis requires a blood sample from the patient, which can be painful.
So that's kind of an introduction to the definition of hypoxemia. I think I need to set the background because we're going to talk about hypoxemia, the definition. We're also going to talk about the different ways to detect hypoxemia. Obviously, this includes the pulse oximeter, which is probably going to be the most widely available outside of clinical detection. And we'll talk also about clinical detection of hypoxemia. So I want to read a couple things that that set the background and why we're talking about the oxygen series. Obviously, COVID-19 has been a challenge for everyone across the globe, and oxygen therapies are the first step in treating any sort of hypoxemic patient, including COVID-19. And I'm sure many of you realize also that pneumonia is the leading cause of death in children under the age of 5. Hypoxemia is a major fatal complication of pneumonia and increases the risk of death many times. It's often not well recognized and managed in settings where resources are limited. This is particularly true in small district hospitals that don't have oxygen. The most reliable detection of hypoxemia could be achieved through more widespread use of pulse oximetry, which is non-invasive and painless to the patient. Pulse oximetry and the availability of reliable oxygen sources in district and provincial hospitals can reduce death rates from pneumonia by 1/3. On Monday, we were on a phone call, and the Minister of Health in the DRC stated that less than 5% of facilities that need oxygen actually have an oxygen supply. In 2018, a study was done that surveyed 78 hospitals across 3 states in Nigeria and found that only 2% had pulse oximeters. In Ethiopia, the authors found that only 14% of hospitals studied had standard operating procedures on oxygen use or healthcare workers trained in oxygen therapy, and only 41% had biomedical engineers and technicians who could maintain the oxygen equipment. So that's kind of the background of why we're going to talk about oxygen for the next several weeks. Every Wednesday, we'll be talking about oxygen. So we now know that we can use pulse oximetry and ABGs, but before we do that, we also need to recognize the clinical signs of hypoxemia.
Before diagnosing hypoxemia using pulse oximetry or arterial blood gas analysis, it is important for providers to recognize the clinical signs and symptoms of hypoxemia. These signs may be different in adults and pediatric patients. In adult patients, early signs of hypoxemia can be restlessness and anxiety. Using pulse oximetry is an easy and non-invasive way to measure oxygen saturation. Although not all signs are noted in all patients, clinical signs of hypoxemia in adult patients can include rapid breathing, fast heart rate, accessory muscle use, an upright position, an inability to speak full sentences, and confusion. A late and ominous sign is pallor or cyanosis. Pediatric patients, unlike adults, may not be able to alert providers or report respiratory distress. Further, clinical signs may be inconsistent and non-specific for pediatric patients. Use of a pulse oximeter is the quickest and easiest way to detect hypoxemia in all patients, but especially in the pediatric population. Other signs of hypoxemia in pediatric patients include weak cry and lethargy, grunting with an inability to feed, fast breathing, wheezing, tracheal tug, retractions, nasal flaring, head bobbing, pallor, and cyanosis. The Silverman-Anderson Respiratory Severity Score may be a valuable tool for predicting the need for escalation of respiratory support and facilitate decision-making for transfer in low-resource settings. This score is used in newborns and infants to determine impending respiratory failure. A score of 0 to 3 is mild respiratory distress. A score of 4 to 6 is moderate respiratory distress. A score greater than 6 is equivalent to impending respiratory failure, and a score of 10 is severe respiratory distress. Hypoxemia is defined by low levels of oxygen in the blood. Receptors throughout the body detect when oxygen levels are low. There are receptors in the medulla oblongata in the brain and receptors in the carotid bodies and aortic arch. When hypoxemia occurs, the respiratory centers in the brain respond by increasing ventilation, usually through increasing the respiratory rate or number of breaths per minute. Patients may experience a sense of shortness of breath, also known as dyspnea. It is important to note that the receptors also detect and respond to pH and carbon dioxide. Elevated levels of carbon dioxide is usually a stronger stimulus for breathing than is hypoxemia. Here is an interesting fact. The normal values for the fraction of inspired oxygen concentration decrease with an increase in altitude. Therefore, normal oxygen saturation is less for our friends that live in high places like the highlands of Peru, Tibet, or Ethiopia.
So I'm going to open it up to the co-panelists now to discuss some of the points that were made, and also to see if there are any questions that need to be addressed in the chat box. Doesn't look like we have any questions yet. Okay, great. So I think what we'll do next then is continue on until we have more questions. So we talked a little bit about pulse oximetry. We talked a little bit about arterial blood gases. And we're also now talking about the clinical signs of hypoxemia. So we're going to go through a couple of videos of actual patients. And I want you to type in the chat box what you see clinically in this video. So just start typing however you can describe this baby.
So I looked up asthma and it said C, C. Well, it just said C.
Okay, so can some participants type in the chat box or the question and answer box the clinical signs that they saw in that video? Oh, could we not?
And I don't think yeah, we couldn't see the video. We could just hear the audio.
Okay, let me try again. Can you see the video?
Yes.
Yes, we can see it this time.
So I looked up asthma and it said C, C. Well, it just said C.
Okay, can you see the video now? He said, now it's okay. Lethargy, great. Severe retractions, chest undraping, lethargic, use of accessory muscles, fast breathing, chest indrawing, abdominal breathing, dyspnea, perfect. So if you look closely at this baby, we'll play the video again so that you can see the retraction of the skin between the ribs, the retraction of the skin under the sternum. The abdomen or belly is moving outward, so a lot of abdominal breathing. And then you can see retractions up by the collarbones and in the neck. The baby is not crying. The baby is listless and lethargic. And then if you look closely, you can also see nasal flaring. So let's play that video one more time so we can actually, those who didn't see it the first time, can see it this time. So play one more time. Can you see the video?
Yes, we can.
Thank you. Here we go again. If you look closely at the nose, you can see nasal flaring.
So I looked up asthma and it said C, C. Well, it just said C.
Great. And the comments in the chat box that you see the head nodding or head bobbing, all of that is exactly what we're seeing. So this child is in pretty significant respiratory distress and needs support. The next step would be to check the child's oxygen levels using pulse oximetry if available, but the child needs respiratory support, even based on clinical signs. Great. So I see that Gideon is asking for the adult patient, which is exactly what I have next. So let's go ahead and look at our next video. And again, in the chat box, I'd love for you guys to type the things that you see in this next video, the clinical signs of respiratory distress. Can you see the video?
Yes.
Wonderful, thank you. Okay, great. So we have gasping, sleepy, intercostal recession, perfect. Tachypnea, accessory muscle recruitment, which you can really see when they scan up and you can see the patient's head and neck. You can see the muscles of the neck working to try to pull the chest out and open to get a breath in. The abdominal breathing is another big sign that this patient is in distress. Subcostal recession, intercostal, abdominal respiration, use of accessory muscles, perfect. If you look at a person who's breathing normally, you will see the chest will expand from the front to the back and also from the sides. And you can tell that that patient's chest is not expanding very well. And so he is using all the other muscles, including his abdomen, the muscles of the neck, etc., to increase the amount of breath that he can get into his body. And yes, he's lethargic. So Dr. Lem, you want to go ahead and comment?
Yeah, I was just noting that in pediatric population, there was a question about what are early signs of hypoxemia. And I was just pointing out that in infants and children, you're more likely to see, as an early sign, the retractions around the clavicle and around the neck. And I believe that's due to kind of premature development or like early development of the intercostal muscles that are less developed than in adults. Whereas in adults, you're more likely to see the intercostal retractions earlier on. Also, you're going to be more likely to see the paradoxical breathing of the between the neck and the belly. As the belly goes out, the neck and the chest muscles retract inwards. And that's more prominent, at least in my experience, with the pediatric populations.
And although not officially a co-panelist, I see that we have Dr. Andrea Murray here, who is also a specialist in pediatrics anesthesia. We also have my good friend, Dr. Francois, on the call. So if you have anything to contribute, it would be greatly welcomed. So you can raise your hand or otherwise indicate that you'd like to share some of your wonderful knowledge as well. Okay, so it looks like we don't have any more questions, so I'm going to keep moving forward as long as your questions have been answered, which will leave us some time at the end of the session in order to go through the emailed questions. Okay, so let's go through our next learning module, which is going to be how do we
In addition to diagnosing hypoxemia, it is also important for healthcare providers to recognize the common causes of hypoxemia in neonates, children, and adults. Hypoxemia is defined by low levels of oxygen in the blood and is detected using arterial blood gas analysis or pulse oximetry. Pulse oximetry is more widely available, but arterial blood gas analysis is more accurate when available. The exact level of oxygen saturation that defines hypoxemia is not clearly defined, as the level at which tissue hypoxia occurs is not known. However, most clinicians agree that an SpO2 less than 90% by pulse oximetry qualifies as hypoxemia. A hypoxemia diagnosis can be made using arterial blood gas analysis. But if ABGs are not available, a pulse oximetry unit can also be used. In the instance where neither tool is available, bedside providers must use clinical signs to guide administration and titration of oxygen therapies. Common causes of hypoxemia in neonates include, but are not limited to, birth asphyxia, respiratory distress syndrome, pneumonia, sepsis, congenital heart disease, meconium aspiration syndrome, and apnea. Common causes of hypoxemia in children include, but are not limited to, acute lower respiratory infections such as pneumonia or bronchiolitis, asthma, meningitis, sepsis, congenital heart disease, perioperative complications, malaria, and trauma. Finally, common causes of hypoxemia in adults include, but are not limited to, chronic obstructive pulmonary disease, asthma, pneumonia, sepsis, trauma, congestive heart failure, pulmonary embolus, and perioperative complications.
Okay, so now we've gone through some of the clinical signs and symptoms of hypoxemia in both pediatric patients and adult patients. And we've talked about diagnosing hypoxemia using those clinical signs, using pulse oximetry, which we'll talk more about, and also using the arterial blood gas analysis. Recognizing arterial blood gas analysis is not widely available. I'd like for Dr. McAvoy just to speak briefly about the indications for using ABGs or arterial blood gas analysis.
Yeah, hi, good morning, everybody from California. Arterial blood gas analysis can be helpful. As Dr. Crawford said, it is a direct measurement of the dissolved fraction of oxygen and carbon dioxide in the blood. Additionally, it gives us information about the patient's acid-base status, as it will give an arterial pH and a calculated bicarbonate concentration, as well as a base deficit. For these reasons, the arterial blood gas analysis can be helpful to better understand the severity of ARDS, although the pulse oximeter can be used and has been validated in this setting for when arterial blood gas is not available. Additionally, it can help us understand if a patient who has a acidosis or hypercarbia is chronic or acute based on the bicarbonate concentration.
Wonderful, thank you. So let's go ahead and talk a little bit more about pulse oximetry. If you don't have arterial blood gases, which is the case most of the time in some of the district hospitals and more limited resource hospitals, then you would try to use pulse oximetry. Pulse oximetry is growing as a resource. So I think most of you have probably heard of Lifebox, and they are, their agenda is to distribute as many pulse oximeters across the globe as possible. So if you were going to try to obtain any resource, it would be a pulse oximeter, because as I mentioned earlier, having oxygen and pulse oximeters in the clinical setting can decrease death by 1/3 in patients that are hypoxemic or with pneumonia. And this is particularly important in children less than 5 years old. So we'll talk more now about pulse oximetry. But if you don't have a pulse oximeter, then using those signs and symptoms that we described and that you saw in the video of the child and the video of the adult. So let's move on to pulse oximetry.
Providers using pulse oximetry to diagnose and treat hypoxemia must understand how the pulse oximeter works and understand the limitations to its accuracy. One major goal for most of our patients, whether stable or critically ill, is to maintain adequate oxygen delivery to all the cells and tissues in the body. Oxygenation is the process by which oxygen from the alveoli in the lungs diffuses into the pulmonary capillaries. Once oxygen diffuses into the pulmonary capillaries, the majority binds to hemoglobin within the red blood cells. The hemoglobin that is bound to oxygen is termed oxyhemoglobin. Pulse oximeters are one of the most valuable monitors in patient care. Pulse oximeters measure oxygenation indirectly and are painless for the patient. Pulse oximeters use probes to shine red and infrared light through tissue beds. Red light has a wavelength of 660 nanometers. Infrared light has a wavelength of 940 nanometers. Sensors in the pulse oximeter detect the amount of light absorbed at each wavelength. Through a process called photoplasmography, arterial blood flow is detected by its pulsatile flow. Pulsatile flow generates an alternating current, designated AC. Non-pulsatile flow in the tissues are canceled out. Non-pulsatile sources include venous blood and tissues. The pulse oximeter then calculates a ratio of oxyhemoglobin to deoxyhemoglobin in arterial blood only. This ratio is then displayed as a percentage on the pulse oximeter screen. The pulse oximeter comes with a probe and a computerized unit. The first step is to place the probe on the patient's finger, toe, or earlobe. In small children and infants, the probe may extend over the entire hand or foot. Next, make sure the unit is powered on. Some pulse oximeters require batteries or charging, so it is optimal to ensure adequate power to the device at all times. The pulse oximeter should display the pulse rate and the SpO2 or oxygen saturation. Many devices also display a waveform. It is important to check that this waveform corresponds to the patient's pulse or the electrocardiogram tracing. This will ensure the accuracy of the values being recorded. There is also an audible beep. That beep corresponds to each heartbeat. It sounds like this. Most pulse oximeters also have the capability to change the tone of the beep with changing values of oxygenation. The higher the SpO2, the higher the tone. The lower the SpO2, the lower the tone. Changing tones with changing SpO2 is called tone modulation. It sounds like this for an SpO2 of 100%. And it sounds like this for an SpO2 of 85%. There are several limitations to pulse oximetry. Most limitations lead to a falsely low SpO2 reading. Movement, shivering, and electrocautery interfere with the probe's ability to detect pulsatile arterial blood flow. Similarly, abnormal heart rhythms can interfere with the pulse needed for photoplasmography. Methemoglobin absorbs light similarly at 660 and 940 nanometers, which leads to an inaccurate ratio and usually an SpO2 approximating 85%. Similarly, Many injectable dyes can also cause a false low SpO2 reading. Carbon monoxide leads to a falsely high SpO2 reading, as it absorbs light at the same wavelength of oxyhemoglobin.
Great. So there's a lot of comments in the chat box regarding pulse oximeters. Lifebox is actually hosting the session next week. So you'll see a lot of their materials. They have some really great materials for triaging patients using the pulse oximeter, instructions on how to use and maintain a pulse oximeter. So I can show you those as well here in just a minute. So I think, Dr. Patel, would you mind just telling us your experiences when you place a pulse oximeter and you're not getting 100% or a high 90s value? What are some things that you try to do to make sure your pulse oximeter is working correctly?
So I think the first thing that I would do is look at the trace to establish whether it's an accurate trace or inaccurate. And whilst I'm trying to sort out the problem, I would increase, if available, I would increase the fraction of inspired oxygen whilst I try and troubleshoot. What I have done is looked at, as mentioned, things that can interfere with the pulse oximeter trace, such as a patient shivering, feeling for the pulse and making sure that the patient's actually got a strong pulse, so is perfusing the distal, sort of perfusing the fingers, and then making sure that the connection and the equipment and the connections are sort of tightly fitted and corrected. And then I would look at other causes, such as methemoglobinemia, for example. So I just work my way back from the patient.
Wonderful, thank you. I think one important thing to recognize is that the pulse oximeter, as per its name, needs a pulse. So if you have someone who is very cold, someone who is on large doses of vasoactive drips, so vasoconstrictors, that pulse may not reach the most distal part of their finger or toe. And so it's really important to recognize when that happens, because your pulse oximeter will not be correct. So in most of the African settings, it's probably not going to be from being cold. It's probably going to be more likely that the patient either is on vasoactive substances or they have perfusion abnormalities to the extremities. So next we're going to go to an example of interpreting a pulse oximeter. So I want the audience to pay attention and type in that chat box again the answers to this simulation using pulse oximetry. So I welcome you all to type in your chat box what you think the answers are.
Can you interpret this SpO2 tracing? What is the heart rate? What is the SpO2?
Wonderful. Okay, so we have established, most people established that the pulse oximeter reading, or the oxygen saturation, is 83 and the heart rate was 55. So we're going to go back through the video, and as you can see, this is on that learning resource platform, and you can actually click on which value you think is the heart rate and which value you think is the pulse ox, or the oxygen saturation. And so we'll get some good explanations about this pulse oximeter reading through that process. So you can see you can click on the area that shows SpO2. Oops.
Can you interpret this SpO2 tracing? What is the heart rate? What is the SpO2?
I think because it's screen sharing, we're not able to click on it. But can you put in the chat box whether or not you believe this data and whether the tracing is accurate or not? So Badima says the tracing, not accurate tracing. Great. So people are starting to recognize that that tracing on the SpO2 is inaccurate. And it's inaccurate because it doesn't correspond to a regular pulse or regular heart rate. And when the tracing on the pulse oximeter is not regular, the pulse oximeter is unable to accurately gather the differences in wavelength absorption. So if your tracing is not consistent, the pulse oximeter may be giving you abnormal or inaccurate data. So it says that the SpO2 is 83%, but in fact, we don't know what the SpO2 is because we don't have a good tracing, which is telling us that the pulse oximeter is unable to determine the accurate pulse oximeter or saturation. So if you saw this tracing, co-panelists, what would you do?
The first thing I would do, I think Dr. Patel had a lot of great comments about troubleshooting the pulse oximetry. The first thing I would honestly do is look at the patient and see if the numbers are correlating to how I believe the patient would be based on their signs of respiratory distress or lack thereof. If I see a patient who looks fine, is able to talk to me, and has that waveform and oximetry reading, then I would be probably more likely to troubleshoot the pulse oximetry in a more calm manner, going through everything. I would be more concerned and with a heightened sense of action if the patient looked like they were in respiratory distress with all the signs and symptoms that we saw in the previous videos. And then I would go through the algorithm that Dr. Patel laid out.
Yeah, wonderful. So if you have any question whatsoever about your patient's oxygen levels, you should start oxygen if it's available until you can get accurate data. And I think that's a really important point, that if you don't have arterial blood gases, if you don't have a pulse oximeter, you must use your clinical signs and symptoms to determine whether you think your patient is needing respiratory support. Great. Anything else about that you wanted to share? Okay, so we are not getting too many questions, so we're ahead of schedule, what we anticipated. So I think it would be a good time for us to go through some of the questions and share some of the resources that are available on the LearnWorlds or the Learning Resource Center site. So there's a lot of questions about how to manage hypoxemia, how to know when to initiate oxygen, how to know when to stop using oxygen, how to use oxygen in our COVID-19 settings. So I'm going to again share my screen. All of this information and all of the discussion for the next sessions will be found online at the Learning Resource Center, as well as the Assist International webpage. So I'll show you some of the other resources that are available to you and everyone. Anyone can sign up for an account on the Learning Resource Center. And it's free and it's open access, and you can share it with all of your friends. So anyone who needs information is welcome to join this online learning course. So there's a course on oxygen, which we're running through this series. There's also a course on COVID-19, as well as a course on the fundamentals of critical care. So we have completed module 2, which is what we wanted to do today. So I also wanted to point out that next week we're talking about triaging hypoxic patients. This session will be run by Lifebox, and they have a great triage tool that is in multiple languages that can be downloaded. There's also a wonderful oxygen wall chart that helps clinical providers decide when to use oxygen, especially with limited resources. So this was developed by some of our colleagues in Australia in consultation with the WHO. So it gives you key points and practical oxygen therapy on how to deliver oxygen if you suspect pneumonia or hypoxemia. And so it gives you a way to work through the questions that you're asking. So we can start at the top. It just wants to give you practical oxygen therapy and preventing infections for hospital staff. Again, this is geared towards COVID-19 patients. So if you suspect and confirm the diagnosis of COVID-19 infection, you put a simple mask, surgical face mask or procedure mask on the patient, and you start infection prevention and control measures. You consider the staff to wear personal protective equipment, and you disinfect all medical equipment that comes in contact with that patient. If you suspect severe pneumonia and confirm the need for oxygen, again, you can use your respiratory signs and symptoms, or you can use the pulse oximeter. So you can see here the adult or adolescent is less than 90% on the pulse oximeter, and a child is less than 90% on the pulse oximeter. So once you confirm that you have less than 90% SpO2 on the pulse oximeter, that gives you the diagnosis of hypoxemia. And so you want to start your oxygen therapy. You can start with nasal cannula or prongs, or you can start with a face mask. For children under 5, you can start with nasal prongs, and you want to adjust the flow to increase to greater than 90%. You can try prone position. We can talk more about prone position. Prone position can be used in the awake patient or in the intubated patient. If the SpO2, despite putting the oxygen on, doesn't increase to greater than 90, then you need to actually advance the level of care that you're providing to the patient. So you can see that reads here, if SpO2 not increased or is still remaining less than 90%, advance oxygen and ventilator care. You want to keep the surgical mask on over the prongs that the patient is wearing to prevent viral spread from the oxygen that's being delivered. You can still have droplet spread. If you're using a nasal cannula, you do not need humidification. So at lower flows, you do not need humidification. So nasal prongs, the oxygen can be given at 1 to 5 liters per minute. Nasal catheter, which is used in infants and children, can be given at 1 to 2 liters per minute. Again, if your oxygen doesn't increase and remains lower than 90%, you want to move up to your oxygen face masks, which you can deliver oxygen at a higher flow at 6 to 10 liters per minute. Or if you have a face mask with a reservoir bag, which is also called a non-rebreather, you can increase your flow to 10 to 15 liters per minute. Venturi oxygen masks are another way to deliver oxygen, and oxygen can be delivered anywhere between 4 to 15 liters per minute. I'm going to stop sharing simply because I can't see the chat box when I'm sharing my screen. So I just want to make sure. Okay. Wonderful. So the website was shared for both Assist International and the online learning. Great. Okay, we have a question about humidification in pediatric patients. Wonderful. So I'm going to continue through the rest of this algorithm, and then we'll have a discussion. So we'll go through the rest of the algorithm and then stop again. Okay, so now we've gotten to the point where we've identified hypoxemia as an SpO2 less than 90%, and we've decided to start oxygen. We can start with nasal cannula or nasal catheter for the infants and children. If our saturation does not increase or go above 90%, we need to give more oxygen. So more oxygen can be delivered using an oxygen face mask or a reservoir bag, non-rebreather, or a Venturi mask, whichever is available. Recognizing that the flows are limited on these to 10 to 15 liters per minute. Once you start to deliver oxygen at that high of level, you need to start thinking about a higher level of care. So if there is a mechanical ventilator or an intensive care unit or a higher way to deliver oxygen, you need to consult those resources at this point in time. So as soon as you move to a non-rebreather face mask, that's when you need to start thinking ICU, if available, or transferring a patient to a higher level of care if that is available. So the resource limitations are going to be your oxygen supply and delivery devices. So you want to assess and monitor your oxygen supply regularly, and you want to understand what oxygen delivery devices are available in your facility, which is why we started this series with the facility evaluation forms. And those forms are not to be turned in, they're for your use and knowledge to understand what is available in your setting. And the rest of this algorithm goes through decontamination and disinfectant. So I'm going to go back to the start of this Learning Resource Center and go through the evaluation of your facility. Whoops, apparently I have to sign back in. Okay, so you can use this evaluation form to become familiar with your own setting. So at your facility, what types of oxygen supply are available? Is it oxygen plants with pipelines, cylinders, or concentrators? At your facility, how do clinicians detect low levels of oxygen? Is it clinically, pulse oximetry, or arterial blood gas analysis? At your facility, what types of oxygen delivery devices are available? Do you have nasal cannulas or nasal catheters? Do you have simple masks? Do you have non-rebreathers? Do you have oxygen hoods for pediatric patients? Do you have Venturi masks? Do you have high flow nasal cannula? Do you have BiPAP? Do you have CPAP? Do you have an ICU with mechanical ventilation? So these are the kinds of questions you need to ask of your facility to understand what resources are available to you. At your facility, do you have bioengineers available for oxygen sources and delivery devices? Who would you call if you need help with oxygen? And then finally, how many pulse oximeters are available at your facility? Okay, so we have some questions about determining the need for humidification, which is a very common question. So if you have low flow oxygen at the rate that you would use for a nasal catheter for children or infants or a nasal cannula, your flows usually only go up to 5, maybe 6 liters per minute on the nasal cannula. And at those low flows, you don't need humidification. However, once you start going up to higher flows for prolonged periods of time, that high flow can lead to drying of the nasal mucosa, of the oral mucosa, and that can cause the secretions the patients may have to become very thick and very tenacious and very difficult to clear. So when you have higher levels of flow, that's when you need to have humidification considerations. Why does a non-rebreather allow higher flow and higher FiO2? Do any of the co-panelists want to handle that question?
Sure. Both Dr. McAvoy and I responded on the chat feed, more or less the same answer. But basically, the non-rebreather, if you want to screen share a picture, perhaps, it has a bag that's attached to the front of the mask. And the oxygen that's delivered either through the tank or through the wall will build up in that mask and balloon outwards. And that provides an extra reservoir or place that contains more of the higher oxygenated content air that patients can then inhale easier. With the nasal cannula, it's unable to hold that reservoir, and basically all of the oxygen that you're putting in through the nasal prongs will collect within the patient's nasal cavity area, the nasal pharynx, but everything else will pretty quickly diffuse out into the atmosphere and doesn't get held on in the same way. So with a non-rebreather mask, there's much less respiratory effort needed to get a higher concentration of oxygen.
So we can go through different oxygen delivery devices. We can start with the nasal prongs. The patients that can use nasal prongs include both children and adults. The flow is in liters per minute, so 1 to 5 liters per minute. Some people will say 1 to 6 liters per minute. The fraction of inspired oxygen delivered, or FiO2, is between 28% and 40%. And so this is a photograph or a drawing of the nasal cannula itself and how it fits on the patient. So the nasal prongs go into each nair on the patient, and then the straps go behind the ears. There's usually a tightening device that you can slide up under the chin, and that will hold the nasal cannula on the patient. So that is this portion of the drawing here. The other side of the tubing is usually quite long so that it can fit to the wall. And so you would plug this side into your oxygen supply. Oh, sorry, apparently I'm not showing the drawing. Let me try again. Thanks, guys. Apologies. Can you see it now?
Yes.
Okay, so this is oxygen delivery devices, the nasal prongs, again, adult and child. Flow is in 1 to 5 liters per minute, and the FiO2 you can achieve, the fraction of inspired oxygen you can achieve, is between 28 and 40%. You can see the nasal cannula fits into the nair of the patient, and the straps go behind the ears. And usually there's a tightening device under the chin that holds the device on the patient's face. And then the other end of the tubing is what you plug into your oxygen supply. So at this low flow, you do not need to consider humidification. If we're talking about the nasopharyngeal catheter, the patients that you can use this on are infants and children. And the flow can only be 1 to 2 liters per minute. So this is a low flow device. But as you can see, you measure the nasal catheter by going from the child's nair or nostril to the front of the ear or the tragus. And that is the length of the catheter that should be inserted into the patient. You can see that it goes through the patient's nostril and goes down into the back of the throat or hypopharynx and is directed towards the trachea. So that's how oxygen is directed straight to the airway. And you can see this is the tip of the catheter if you were to look in the child's mouth. So again, this is a low flow system of 1 to 2 liters per minute, but because the flow is directed towards the trachea, you can actually get an FiO2 of 45 to 60%. Again, nasopharyngeal catheters are used in infants and children. A simple oxygen face mask is another device you will see for delivering oxygen. These masks can be used in both children and adults, assuming the mask is small enough for the child's face. They come in different sizes. The flow can be anywhere from 6 to 10 liters per minute, and the fraction of inspired oxygen is between 44 and 60%. So here is a picture of the mask. You can see this is where the oxygen comes into the mask. And you can see that it fits over the patient's mouth and nose. And usually there are 2 tightening straps on either side, so you can tighten the mask onto the patient's face. One thing to point out in the setting of COVID-19, when you're creating higher flows or pressures into a patient's airway, you risk having increased viral spread. So with the nasal cannula, with the nasal catheter, and with the simple oxygen face mask, you can have some viral particles that escape. So if you can put a surgical procedure mask over the patient while they're on these oxygen devices, that is advised. The simple mask, you can see, has these holes in the side of the mask. So when the patient exhales, they can exhale the viral particles to the room. This is the oxygen face mask with the reservoir bag. We also call this a non-rebreather. It can be used in both adults and children. Its flows can go up to 15 liters per minute. It's not to be used with low flows, so the lowest flow is typically 10 liters per minute. If you don't have another device, it's okay to use lower flows, but it's designed to have 10 to 15 liters of flow, because what happens is the reservoir bag will inflate with extra oxygen, so that every time the patient takes a deep breath, they have the oxygen that's flowing in as well as the oxygen in the reservoir bag. And that allows the FiO2 delivered to reach somewhere between 60 to 95%. So this is a very high FiO2 for use in these bags, in these masks rather. The mask fits on the patient's face just like the simple oxygen face mask does, but you can also see it has exhalation ports as well. So when the patient is wearing this mask and they're suspected of having COVID-19 or SARS-CoV-2 positive, you would want to place a procedure mask, a simple mask or face covering over the patient, so that when they exhale, it will contain the potential virus that is exhaled by the patient. The final one we'll discuss is called Venturi oxygen face mask. This can be used in adults and children. The flows can be anywhere between 4 to 15 liters per minute. And the fraction of inspired oxygen delivered depends on the valve that you place on the mask, which I'll show you in a second, but it can be anywhere from 24 to 60%. You can actually adjust the flow of oxygen versus air by using different valves, and that adjustment of flow will determine the FiO2 or oxygen that is delivered. So some of these Venturi face masks have valves that are built in that you can twist to allow the opening to be bigger or smaller, allowing more or less air to enter. The more air that enters, the lower the oxygen FiO2. The smaller the hole, the less air that enters, the greater the oxygen concentration. They come in different colors, so you have either a valve that has a twist that you can change the values, or you have different valves that you can put into the device. A blue valve, a white valve, an orange valve, a yellow valve, a red or pink valve, and a green valve. Each of these valves are different sizes, allowing different amounts of air to mix with oxygen, therefore allowing different levels of FiO2 to be delivered and different levels of oxygen flow. Okay, we have 17 new messages. Are any of those questions we'd like to discuss?
I think so far we've answered most of them. For tenacious mucus in the lower respiratory tract, is pulmonary lavage ever considered? I said it can be useful, but we can also try more basic medical therapies, if possible, such as saline or carbocysteine, for example, if available.
Okay, wonderful. Were you able to see that picture this last time with the oxygen delivery devices?
Yeah.
Okay. Okay. So I think what we should do now is go through the questions that were sent prior to, and just make sure we've answered all of the questions. So so when you registered for the series, you were able to put in questions. So we'll go through those. How best to monitor oxygen therapy? And I think we've answered that with, if you have pulse oximetry, that would be the highest recommendation to check your patient's oxygen saturation. If you have arterial blood gas, that's another great way to check your oxygen, your pH, and your carbon dioxide. If neither of those are available, then you need to be able to recognize the clinical signs of respiratory distress and hypoxemia. And we showed the video of the small child as well as the video of the adult showing the signs of clinical distress, respiratory distress. How can pulse oximeters be used in the follow-up of patients with mild illness for detection of deterioration? And what is the strength of evidence? The pulse oximeter is incredibly easy to use. You place it on the patient and you have your answer in less than a minute. So I think that the pulse oximeter can be used anytime. It doesn't hurt the patient. If it's widely available, you can put it on the patient at any time. So if you have a patient who was mildly hypoxic and received therapy and did better, once they're able to have a normal saturation without oxygen, then you can take the pulse oximeter off. However, if you see changes in the clinical signs and symptoms in that patient, then you should reconsider placing the pulse oximeter and checking to make sure that patient still has adequate oxygenation. So you can use the pulse oximeter at any time. How can one ascertain the quality of medical oxygen at the point of care before starting the oxygen therapy? The answer to this question, excuse me, is going to be dependent on your facility. So that's why it's good to understand the resources that are available in each situation and each setting. If you have oxygen pipelines or oxygen plants, most likely you have bioengineers that are running tests on those plants and on those pipelines. If you have any question, there's also monitors on those pipelines to determine whether the pressure of oxygen is adequate. Additionally, most of those monitors have alarms. So if the pressure were to drop, you can have an alarm. If your facility doesn't have an oxygen plant or doesn't have piped oxygen, then it can have either oxygen concentrator or cylinders. And again, the cylinders are usually equipped with pressure monitors that need to be looked at regularly. And the oxygen cylinders also, or concentrators also have indications as to whether they're functioning or not. So in an ideal setting, you would have bioengineers to help you with that. But later in the session, in the series rather, we're going to have 2 sessions dedicated exclusively to supply chain management and oxygen delivery systems. Okay. This is a great question. How can someone measure the P to F ratio where ABG tests are impractical? This is a very common question. And for those of you who aren't familiar with the P to F ratio, the P is PaO2, or the partial pressure of oxygen dissolved in the blood. And the F is the FiO2, or the amount of oxygen that's being delivered to the patient. If you look at the P to F ratio, you can determine how well the oxygen that's coming into the patient's body is going into the bloodstream. So if your P to F ratio is low, that means you have a problem getting oxygen into your bloodstream. Most of the time, this is because of a diffusion problem in the lungs. So it's very common when you have pneumonia to have a low P to F ratio. When we diagnose ARDS, or acute respiratory distress syndrome, we use the P to F ratio as part of that definition. If you don't have an arterial blood gas, you don't have the PaO2, so it's difficult to determine the P to F ratio. However, one of our brilliant colleagues in Rwanda, Dr. Teogene, developed the Kigali modification for diagnosing ARDS. So what you can do in that situation is use your pulse oximeter. You can use the SpO2 to FiO2 ratio. And if that ratio is less than 350, then you can actually diagnose ARDS in that situation. So even if you have limited resources and ABGs are unavailable, you can use the Kigali modification to determine whether or not your patient has ARDS or a severe oxygen diffusion limitation.
I just texted a link to the group of a chart that illustrates the differences between the Berlin criteria and the Kigali modification. And the other thing I'll point out, which I'm sure we'll talk about later, is the imaging is also different, with chest x-rays being replaced with ultrasound findings as an option.
Wonderful, thank you, Andrew. I want to just also point out to the audience that all of these resources are available on the Learning Resource Center. Some of them are under the Oxygen series, some of them are under the COVID-19 series. What we will do after this webinar is actually move anything that you ask in the question box. We will actually provide those resources in the Oxygen series on the Learning Resource Center. So after the webinar, you're welcome to go back and you can see all of those references. That might take us 1 to 2 days, but all the references that we have talked about and all the references that you have asked for will be provided on the Learning Resource Center. So please check back for that. Another great question is, what are the actions to be prohibited during oxygen therapy? The first thing that comes to my mind when someone is on oxygen is that oxygen is very flammable. So being near any sort of spark or fire or smoking is 100% prohibited, because it's very dangerous to have oxygen near a fire or flame. Can you think of any others, Dr. Patel or Dr. Lim?
So the most common example of that I can think of is, you know, obviously smoking in more of an outpatient setting or ER setting, but in the operating room setting, any electrocautery near the face or neck area is definitely not acceptable.
Yeah,
Yeah,
so
especially in airway surgery.
Yeah.
I also thought it would be useful to be wary of over-oxygenation in certain cases as a possible hazard.
Yeah, agreed. I think it's a little bit, so over-oxygenation, having too much oxygen for too long can actually cause damage to the lungs. I think most of the time we think of that is when patients are on mechanical ventilation. It's a bit more difficult to do with some of the non-invasive oxygen delivery devices, but definitely something to consider. What are the benefits of face masks versus nasal prongs? I think we talked about. What's the amount of oxygen supplied by various devices? Hopefully that series of pictures and tables describing the oxygen delivery devices was helpful to answer that question. And again, we will post that on the Learning Resource Center under the oxygen series. What are the benefits of prone positioning? I'm going to let Dr. Lim talk about prone positioning. Dr. Lim has been working extensively in the ICU dealing with COVID-19 patients. Also, if you look under the COVID-19 course on the Learning Resource Center, we have information already available on prone positioning in the awake patient and prone positioning in the intubated patient, as well as a video for how to get your patients in prone position when they're intubated.
Yeah, I'm going to try to share my screen. I don't know if this is going to work. Let's see if it does. You know, I'm not going to try that right now because, but basically, I sent out a link on the chat of a basically just a quick image of prone positioning. If that doesn't work, you can use Google Images. But prone positioning is really optimizing what's called the ventilation perfusion matching of the lungs. The best way to think about this is that when a patient is lying down, let's say, for prolonged periods of time, which is very common in the ICU or even in a hospital ward setting, the lower part of their lung collapses downwards. Imagine like a sponge that is normally nice and aerated, but with the weight of the chest cavity of the patient over time, that will collapse down on the lower areas of the lungs. And those alveolar units are not going to accept oxygen into the blood as well as it normally does. So proning was first designed for acute respiratory distress syndrome to improve the areas of oxygenation. When you then flip the patient over, you've reversed the process so that more blood will blood tends to follow gravity, will tend to be on the lower aspects of the patient. So when you flip them over, then you reverse the process so that areas of the lung that have better alveolar units that are not as collapsed will then accept more oxygen and also have more blood that flows to those areas that can provide better transfer of oxygen from the alveoli to the blood. So it improves oxygenation, which has direct effects of the patient, but it also evens out the potential for lung damage caused by prolonged hospitalization by evening out the effects of that alveolar collapse over time.
Thank you. So I want to just point out that we do have a course on COVID-19. We hosted a webinar with our friends in Rwanda on May 6th. So you can actually go through all the resources that we talked about in that webinar, which is similar to this one. The LifeBox materials I mentioned are all listed here. Oxygen delivery devices, including the graph that I showed. And then there's a section on prone positioning. So you have a protocol for awake prone positioning, a video for intubated, and more information on how to do awake prone positioning here. So a lot of these resources that are in the COVID-19 course, we will move to the Oxygen series course so that you can see those as well. Great. Okay. How much oxygen is enough oxygen? Does anybody want to type the answer in the chat box? How much oxygen is enough oxygen? What is the goal, SpO2? We have a lot of shy participants. Greater than 90%, wonderful. 94%, okay. So we consider an SpO2 of 94% or greater to be normal SpO2. When you have hypoxemia and you're delivering oxygen therapies, your goal is greater than 90%. So you're not aiming for perfection, you're aiming for good oxygenation. So an SpO2 greater than 90% is okay. In pregnant females, we shoot for a higher goal. We have a higher goal for pregnant females. So you want to have an SpO2 greater than 92 to 94% for those patients. I think right now is a really good time for the quiz. So I'm gonna share with you this quiz and have you type answers to the quiz in the chat box. I think that will be a good way to do this. So we're going to go back to the oxygen series, and you will note that at the beginning of the course, I gave you a quiz. Here's the pre-course quiz. So now that you've had part of this course, we'll let you test your knowledge. Okay, so how confident are you in managing hypoxemia and oxygen therapy in pediatric and adult patients? Are you totally confident? Are you confident? Are you not so sure? I do not understand it at all. So this is for you to fill out for yourself. I'm going to say that I'm fairly confident, and I'm going to go to the next question. Is the following statement true or false? Clinical signs are not reliable predictors of hypoxemia. True or false? Clinical signs are not reliable predictors of hypoxemia. I'm going to say true. And I know the answer because I wrote the question. But the reason clinical signs are not always reliable predictors of hypoxemia is that some patients may be hypoxemia, but not display obvious signs of respiratory distress. Other patients may not show clinical signs until the hypoxemia becomes very severe. This is a good question to demonstrate the importance of pulse oximetry. If you have a pulse oximeter, you can determine immediately whether or not your patient needs oxygen support or oxygen therapies. Okay, let's go to the next question. Sumaya, a 4-year-old female child, presents with cough and fast breathing. Oxygen saturation by pulse oximeter reads 88%. Does she have hypoxemia? Okay, I'm going to say she does. Hypoxemia is defined by an SpO2 less than 90% for most patients. If your patient has chronic COPD, your saturation may be less than 90%. If your patient lives at high altitude, your SpO2 may be less than 90%. And again, in pregnant patients, we want to have a higher SpO2. But for most patients, an SpO2 less than 90% defines hypoxemia, and that patient would need oxygen. Is the following statement true or false? Normal oxygen saturation ranges from 80 to 98%. Okay, I'm gonna say false. Hypoxemia is defined by an SpO2 less than 90 to 94% in most patients. Wonderful. Is the following statement true or false? A good way to ensure accuracy for the recorded saturation of a patient connected to a pulse oximeter is by visualizing a regular pulse wave for 30 seconds. True or false? The answer is true. Remember, the pulse oximeter needs to record the pulse over time and discount the non-pulsatile tissues. So if you don't have a regular pulse, you have inaccurate pulse oximeter data. So if you see a regular pulse wave for 30 seconds, you can assume that your pulse oximeter has good information to determine the oxygen saturation. True or false? Blood gas analysis is less accurate than pulse oximeter for detecting hypoxemia. Blood gas analysis is less accurate than pulse oximeter for detecting hypoxemia. I love all these answers. Thank you for participating. Okay. They're still coming in. Okay, great. I'm going to say false because the blood gas analysis is more accurate than SpO2 for detecting and diagnosing hypoxemia because it directly measures the saturation and concentration of blood, of oxygen in the blood. Okay. Hypothermia and poor perfusion can affect the pulse oximeter reading and accuracy. True or false? Great, you all know the answer is true. Hypoperfusion and vasoconstriction can decrease the accuracy of SpO2 monitors because it interferes with the pulse detection and photoplasmography. Great. Okay, this is multiple choice. Which one of the following is not correct about pulse oximetry? So which one is not correct? SpO2 is the oxygen saturation and is used to detect hypoxemia. Pulse oximeters have an audible beep that can determine if the heart rhythm is regular or irregular. Pulse oximeters help to diagnose hypercarbia or high levels of CO2, carbon dioxide. Pulse oximeters beep with each heartbeat, allowing the provider to calculate the heart rate. So the answer is the one that is incorrect or not correct about pulse oximetry is that pulse oximeters help diagnose hypercarbia or high levels of carbon dioxide. Pulse oximeters cannot detect carbon dioxide. They only detect oxygen. The SpO2 is the oxygen saturation, and it is used to detect hypoxemia, which is what we've been talking about today. Pulse oximeters have an audible beat that can help determine if the heart rhythm is regular or irregular. This is not something we've talked about explicitly today, but it's something that you can hear, and I can demonstrate with the pulse oximeter that I have here. Because there's an audible beep, you can actually hear whether it's regular or irregular. Each beat corresponds to each heartbeat or pulse. So pulse oximeters beep with each heartbeat, allowing the provider to calculate the heart rate. If you can hear a regular beat, you can use a clock or a watch, and you can calculate your patient's heart rate. Is the following statement true or false? If there is no pulse oximeter available, clinical signs can be used to guide administration and titration of oxygen therapy. True or false? Wonderful. So the answer is true. If you don't have an arterial blood gas and you don't have a pulse oximeter, you need to recognize the signs and symptoms of respiratory distress and hypoxemia, and you can use that to guide your oxygen therapy. Okay, only a few more questions left. Is the following statement true or false? For oxygen delivery via nasopharyngeal catheter in infants and children, a 6 French or 8 French catheter with a length equal to the distance from the inner edge of the eyebrow to the outer edge of the nostril can be used. True or false? This question might be somewhat more difficult because if you paid attention during the earlier discussion, we talked about measuring the nasopharyngeal catheter from the nostril to the tragus of the ear or the front of the ear. But you can also use the inner edge of the eyebrow. So either of those anatomic landmarks can be used to measure the nasopharyngeal catheter length. Okay, is the following statement true or false? Simple face mask oxygen use is limited to flows less than 6 liters per minute. True or false? Okay, the answer is false. You can use a simple face mask and use flows up to 6 to 10 liters per minute. Flows less than 6 liters per minute are restricted for nasal cannulas. Okay, a couple more questions and then we'll probably wrap up this session. Which of the following is the most correct statement regarding bag mask manual ventilation? We have not talked about bag mask ventilation, so I'm going to go ahead and skip that question. Which one of the following is not an indication for oxygen therapy in adult patients? Cardiac arrest and advanced cardiac life support, an oxygen saturation less than 90% by pulse oximetry, respiratory distress with respiratory rate greater than 26 breaths per minute, and acute kidney failure requiring renal replacement therapy or dialysis. Which one is not an indication for oxygen therapy in adults? Wonderful. So the answer is renal failure is not an indication for oxygen therapy. Okay, I just looked at the clock. I lost track of time and it's already been an hour and a half. So I've had a lot of fun with you, especially with the quizzes and the good questions. So really love the participation. I also want to thank my co-panelists, Dr. Lim, Dr. Patel, and Dr. McAvoy. I see a lot of friends on this. I see Honorine. I see a lot of people that, that we love. So I'm happy to see you, Dr. Dati. I see your face. Really lovely to see all of our friends. We hope this is useful. We really want to give you the information that you need. So today we talked about diagnosing hypoxemia and using pulse oximeters. Next week we'll talk about triaging patients using the LifeBox pulse oximeter, how to use the pulse oximetry to determine how to best treat your patients. And then in the following sessions, we'll talk about oxygen delivery specific to children and infants. And then we'll have another session on oxygen delivery specific to adults. And then we'll talk about oxygen supply and management of oxygen supply and the supply chain. So thank you so much for joining us. And I hope this was useful. If you have suggestions or feedback, feel free to email me. My email address is on the Learning Resource Center. Again, the Learning Resource Center is created for all people who want to learn. It's free, it's open access, so share it with anybody that you think would need those resources. The resources we talked about today will be uploaded to the Oxygen series in addition to the videos that are already there. So thank you, and I'll turn it back over to Monica and Chase.
Thank you, Anna, and thank you again, everyone, for participating and for our presenters. This was a fantastic session that lasted 90 minutes. Before we wrap up, we do want to just show a QR code for a WhatsApp group that we have created for this series. Please join. The code is up, and if you have any questions about it, please email us at echo@assistinternational.org. We will be posting the session recordings. The materials are all on LearnWorld. Thank you very much to Anna for that. And then we will continue this conversation throughout this series through the WhatsApp chat group. So thank you again. I don't think we need to launch the poll, Anna, is that correct? Because
yeah, I think the test kind of did it. Yeah, thanks.
Okay, fantastic. So thank you everyone again. We'll leave the session open for just a few minutes if anyone has any final questions in the chat, but otherwise have a great day and we'll see you again at the same time next week.
And I am just going to once again put the link there. So if you want to go to the LearnWorld site.
I'm happy to address one question that came up on the chat while people were answering the questions. It was what SpO2 is about to have a cardiac arrest. And I just responded that there is not a single number of SpO2 that causes a cardiac arrest. But a value less than 85% to me is extremely concerning, that the heart is not getting enough oxygen that it needs to function. But of course, if somebody already has heart problems, or other conditions like sepsis, the oxygen demand becomes higher and that they may have poor function or leading to cardiac arrest at potentially a higher value.
Yeah, so I think that's a really great question and a great point, Andrew. Thank you. The reason we say hypoxemia is defined as less than 90% or normal pulse oximetry, normal SpO2 is 94%, but in pregnant women it may be higher or lower, etc., is that hypoxemia is a measure of oxygen in the blood. It doesn't measure the oxygen that is being delivered to cells and tissues, which is the most important thing. So oxygen delivery to cells and tissues, if you remember from the earlier video, is actually called hypoxia. Low levels of oxygen in the blood is hypoxemia. So in order to determine the level of hypoxemia, which leads to hypoxia or lack of oxygen in the cells and tissues, is really unknown. So the normal SpO2 is difficult to determine So it's probably an individual number for the clinical context, whether the patient is pregnant, whether the patient has a systemic inflammatory response, et cetera. So the amount of oxygen at which you start to have cellular death is not always known. So cardiac arrest is going to be not only from low oxygen, but also from a lot of other factors such as acidosis and functioning of your normal adrenaline or catecholamines. So it's not one answer and it's not directly related. So it's a lot of other things that can contribute to cardiovascular collapse and arrest. Any other questions? We still have 93 participants, so I don't know if they signed in and walked away, but it'd be great.
There were also a few questions related on the email related to basically the supply of oxygen and being concerned about limited supply. I know that this is going to be addressed further in the supply chain, but I would just say that as it pertains to this lecture, using the right device for oxygen is really important, and using them properly. So for example, some people might think that if you are running out of oxygen, then using nasal cannula at a higher liters per minute is better, or I would say would save more oxygen than using a non-rebreather, but in fact it will waste more oxygen if you have a nasal cannula at 10 liters per minute compared to a non-rebreather at 10 liters per minute, because the nasal cannula doesn't have the bag to create a reservoir. So, I think that by properly using all the devices, as Dr. Crawford laid out in the device section, you're actually more likely to save oxygen.
It's a great point.
We did have one question just come in French in the chat box.
Yes. Je n'en comprends pas.
So I believe the question is, what is the normal oxygen saturation in pregnant women and newborns?
I think so too.
Yeah.
Honorine, you are unmuted. Can you answer this question for us, please? En français, s'il vous plaît.
Et il est en train de demander la saturation d'une femme enceinte, saturation normale. Et vous avez dit qu'elle peut avoir même 90, entre 90 et 94 comme ça. J'ai répondu.
Thank you. And there was another question that just came in. Is there any scientific study that shows too much oxygen in newborns causes blindness?
Yes. Reema, Dr. Patel.
I mean, I'm not sure about the exact study, but it's a well-known sort of phenomenon that hypoxia in the newborns can cause sort of retinopathies and blindness. So yeah, I'd be wary of that.
So I will place a reference for that particular concern in the oxygen series online, so you can read more about retinopathy in newborns. Honorine, can you see Brigitte's question in the chat box and interpret for me?
She was asking, with the COVID patient, is there a poor fixation of oxygen to hemoglobin, and the oxygenotherapy will become difficult for the patient with COVID?
Thank you. So oxygenation in COVID-19 is one of the biggest problems. The SARS-CoV-2 virus can attack many different organs, but we're seeing that the lungs are attacked the most. And so yes, COVID-19 patients have severe hypoxemia, especially late in the disease. There's a phenomenon that is described in COVID-19 patients where they are called happy hypoxics. Happy hypoxics because they don't show signs of respiratory distress, but they're severely hypoxic down into the 80s. You want to translate, Honorine, por favor?
Pour les patients avec le COVID, il semble que le virus de COVID-19, il attaque beaucoup des organes où il attaque aussi les hémoglobines, tout ça. Et puis, le patient peut avoir l'hypoxie sans avoir les cliniques qui présentent l'hypoxie. Oui, c'est ça.
So additionally, the receptor, the virus binds to a receptor called the ACE2 receptor. The ACE2 receptor is also found in the vascular endothelium. So we believe that the SARS-CoV-2 virus affects not only the lung cells, but also the vascular cells. Honorine. S'il vous plaît.
Et il semble que aussi le COVID, le type de COVID attaque les cellules endothéliennes et puis ça va empêcher la bonne oxygénation des tissus.
The amount at which the COVID virus affects hemoglobin, I don't think is a direct cause, but we are concerned about blood clotting. These patients have a higher incidence of DVT and PE, and we also are suspecting they may have microvascular clot as well.
Yeah, l'hémoglobine, c'est pas quand même le très grand problème que nous avons aussi. Le patient a un grand problème de développer les embolies vasculaires, embolie pulmonaire et embolie des veines et des membres inférieurs. C'est pourquoi tous ces patients aura des micro-embolies dans les vaisseaux pulmonaires.
Merci. Honorine is my sister in Rwanda. She's an excellent anesthesiologist and a burgeoning intensivist. So many thanks to you, Honorine.
There are quite a number of questions coming in now in the chat box. I do want to be cognizant of our Stanford team's time, so we can take a few minutes to try to answer them now or address them in the WhatsApp group. I'm not sure what your timing is like. Do you want to continue this until the end of the hour?
Yeah, we can continue for a few more minutes. I'm going to just refer everyone back to the Learning Resource Center because a lot of these questions are answered in materials there. I also want to reassure the entire group that all of these questions at the end of the session, we will print them out. We will answer them and we will provide references. So you can always come back and read the answers and understand where the answers originate. So Lucy is asking the best way to determine oxygen needs in a patient with an SpO2 greater than 90%. I think that if your SpO2 is greater than 90% and the patient is not on oxygen, then you need to assess the clinical signs and symptoms of respiratory distress. If the patient is on oxygen, then you want to leave them on the oxygen as long as their SpO2 is above 90%. Again, we would have a higher goal in pregnant patients of 92 to 94%. So if the patient's saturation is 90%, you would want to increase the amount of oxygen that you're delivering to that patient. Anything to add?
I was going to address another question about the question reads, please discuss prolonged use of face mask over O2 delivery device and the effect on patient rebreathing carbon dioxide. I think that's a really excellent physiologic question and concern to have. There's not a large concern for rebreathing carbon dioxide during any of these situations because the environmental oxygen level is usually 21% or so. Our bodies are used to inhaling carbon dioxide to a certain degree. So there isn't any significant change when dealing with a very hypoxic patient. Also, the functions of expelling carbon dioxide or getting rid of carbon dioxide and obtaining oxygen are somewhat separate. So the body's very good at getting rid of carbon dioxide. So when a patient is only low in oxygen and hypoxic or hypoxemic, they tend to be breathing quickly. So actually they tend to be ventilating very well and actually have a low carbon dioxide level that is usually expected. And so it's not usually an issue that the patient is rebreathing carbon dioxide. It's never an issue, I would say. And then the other point is that there's a lot of discussion about the differences between COVID patients and how to manage. And I think for the purposes of this talk relating to oxygenation, I think that really if you provide oxygen and assess patients for oxygenation, as Dr. Crawford is saying, you're going to do the right thing for the patient. There's a lot of finer points of discussion that I think we'll get into later with more complicated delivery of oxygen and mechanical ventilation, where there is still a lot of debate amongst the experts about how best to manage it. But I think that for the purposes of this talk, you want to have an oxygen range that's above 90%. The experts usually recommend between 92% and 96%. But the idea being that you want to keep them well oxygenated, but not too highly oxygenated.
So I have a lot of great questions coming in about COVID-19 specifically, and thanks to Dr. Lim and Dr. Patel for helping to answer these questions. The initial thinking when COVID-19 first started was that we would treat, and this is to Gedeon, who I always pronounce his name incorrectly, but he's my friend in the ICU in Sheashika. We initially thought that COVID-19 was very similar to ARDS. And what we're finding is that early in the disease, when the patients first become ill, that their lungs are different. They're not the fluid-filled, stiff lungs with poor compliance as in ARDS, but that later in the disease, the patients actually do progress to have very stiff, fluid-filled lungs, very similar to ARDS. So the presentation of the patient can be somewhat confusing, and the management can be somewhat confusing because early in the disease, they're able to actually ventilate and breathe very easily, but their oxygen levels are low. Early in COVID-19 management, many people, many institutions across the globe were intubating early and placing these patients on mechanical ventilators early. But that thinking has now changed because if we can prevent further lung injury with the ventilator and allow patients to just receive supplemental oxygen and prevent them from being placed on mechanical ventilation, we think the outcomes may be better. The patients that are placed on mechanical ventilation then are the ones that are very, very ill and very, very difficult to oxygenate with severe respiratory distress, severe tachypnea, and severe hypoxemia. So in that patient group, they need to be placed on mechanical ventilation. So some of the techniques that we'll use early on is simply oxygen delivery. You can start with a nasal cannula. Then you eventually move to a non-rebreather. Another technique that's used in some of the higher resource settings are high flow nasal cannulas. And these flows are very high, so they require humidification. But high flow nasal cannula is not a normal nasal cannula at high flow. It's a very specialized nasal cannula. And because the flows are so high, it can actually generate a small amount of PEEP. The flows are on the order of 25 to 30 liters per minute. This is a specialized device. I've not seen it available in my experience in some of the African countries in which I've worked. So we can use high flow nasal cannula to deliver higher levels of oxygen in a small amount of PEEP, and this is in spontaneously breathing patients. Another resource that may or may not be available is non-invasive ventilatory masks that deliver positive pressure. These are things such as BiPAP and CPAP. Those devices are not widely available. So the best resource for some of the facilities with limited resources is actually to get a non-rebreather mask or a high flow nasal cannula, which may or may not be available. Once you have on high levels of oxygen, then proning is something that we would consider simply because it changes the amount of oxygenation and perfusion.
Something that we've actually tried here in the UK is awake proning. I'm not sure about the evidence base for that, but if you're finding in the low resource settings that you don't have ventilators or access to some of this equipment, it might be worth trying awake proning to see if that helps. So
there's a protocol on the Learning Resource Center for both awake proning and intubated proning. Proning is has very good evidence in the intubated patient with ARDS in improving oxygenation. In the awake patient, we have less evidence. So it's more of, if it works in the intubated patient, maybe it will work in the awake patient. There was one article that came out this week that actually suggested that awake proning may not improve oxygenation, but I think the evidence is weak and it's still to be determined. So if your patient is doing very poorly and they're on the highest level of oxygen that you can provide at your facility, you may want to consider having that awake patient turn themselves over onto their stomachs and lie on their stomachs for a few hours to see if their SpO2 will increase on the pulse oximeter. Usually in the awake patient, they prone themselves and they prone themselves for a couple hours and then you turn them back to the supine position. If the patient is intubated, there's also strict protocols that must be followed to avoid complications such as dislodgement of lines, tubes, and drains. And the prone patients that are intubated are usually prone for about 16 hours before you turn them back supine. It requires a team of bedside providers to do it safely. There's a protocol and also a video demonstration on the COVID-19 course on the Learning Resource Center, if you want more information about that.
I'll add that awake proning is fairly common in the emergency departments, at least in the United States and similar settings. One time where you wouldn't want to try awake proning is when somebody is not able to protect their airway for any reasons. For example, if they're very somnolent or sleepy from their hypoxemia or respiratory failure, or if they have a high risk of vomiting. And that's because they could vomit into their airway and cause worsening lung damage, and all the reasons that we would probably move to intubate those patients sooner.
Wonderful. Monica and Chase, I think we should wrap up because Dr. Patel and Dr. Lim and I are probably tired.
Yes, absolutely. And thank you all so much for this almost 2-hour session. We still have 68 participants on the call, so that's fantastic. Again, everything will be shared. Everyone will receive these recordings or the ability to access all of the resources through ourselves and the Stanford team. And we will see you all again here next week. Thank you very much. And we're going to end this session right now.
See you next week.
Bye, everyone. Thank you.
Thanks.